Kulkarni and Dr. Amodu here to teach you everything you need to know about heartburn, how to prevent it, and what the long-term solutions could be for you. So we're going to have you stand right over there, please.
Perfect, perfect. Well, thank you guys so much for coming. Thank you for taking time out of your busy Thursdays, coming and hanging out with us. Hopefully we can teach you, this area here is good, okay. Hopefully we can teach you guys a little bit about reflux. I know we've had a lot of patients coming in kind of asking questions about GERD, reflux, and the things that we can kind of do for you. So we'll just give you a little bit of background about ourselves. Dr. Sayali Kulkarni, I just joined Rome recently. A few months ago. I started in January, did my fellowship in minimally invasive robotic surgery down in New Jersey, St. Joseph's Hospital, and now I'm here as an attending. And this is my partner.
I'm Dr. Leo Amodu. Started at about the same time, sorry. Same thing, trained in bariatric, foregut, and minimally invasive surgeon, predominantly a laparoscopic and robotic surgeon. Did my residency in Long Island and my fellowship in Cleveland, Ohio. Happy to be here, and thank you for coming.
Perfect. And then when we're going through the talk, we'll just keep it kind of like an open discussion. Feel free to stop us at any time. We don't really want it to be kind of, us lecturing at you guys. You guys have any questions, raise your hands, and we'll just kind of keep it like a discussion, okay? Yeah, perfect. So we kind of wanted to start off basically saying how reflux is a little bit more than just heartburn. So let's get into it. Next. Oh, I gotta hit the button?
Yeah, the keyboard.
Oh, right here. Okay, so I'll just stand over here then. All right, perfect. Okay, so we just introduced ourselves. Myself, Dr. Kulkarni, this is Dr. Amodu. We also have a third partner. He's our senior partner, Dr. Hall. I think a lot of you guys might be familiar with him, but he also helps us do bariatric cases. He was the first person here who was doing bariatric cases, hiatal hernias and everything. So we're excited to join him. So let's start a little bit about talking about reflux symptoms. And let me know if you guys have ever experienced any of these symptoms or anything else that you might think classifies as reflux. So even more than just reflux, it's a pretty broad category of symptoms. So you can have basically trouble swallowing, things like food or liquid starts coming back up, you have acid burning in the back of your throat. A lot of the times the symptoms, we get a lot of patients coming in and saying that the symptoms are worse when they're lying down. So either they're getting up from bed or they're lying down and they're kind of having all this acid coming back up. Actually, the number one common symptom for reflux is chest pain. So a lot of people don't know that, and it's not often acid in the back of your throat, but it's just chronic chest pain is very common. So what is reflux actually? So this is just a little bit of an anatomical photo. So you have your food pipe or your feeding tube. That's your esophagus where your food is coming down. This area is your stomach where all the food is kind of hitting, and then it progresses deeper down into your small bowel. So everything, your esophagus is up here in your chest, and your stomach is down here in your, your stomach is down here in your abdomen area. Both of those are separated by something called your diaphragm. So that's super important because the diaphragm plays a very important role in reflux, hiatal hernias, things like that we're going to be talking about next. So there's actually a valve here that helps us keep the acid in our stomachs. So your stomach is coated with cells that are meant to contain acid. Acid has a lot of, very acidic properties, obviously. Once that acid starts coming back up into your esophagus, that's when you get that burning sensation because the acid is not supposed to be in your esophagus. That causes burning. So what's a hiatal hernia? So we're getting into why some patients may have something like reflux. A cause of reflux can be a hiatal hernia. So what that is just like we talked about, your esophagus is up here in your chest, your stomach is down here in your abdomen, and they're separated by the diaphragm. So the diaphragm actually keeps your stomach down, keeps your esophagus in place, just like this is normal anatomy. What happens with a hiatal hernia is that there's a bigger opening in your diaphragm, and this can happen, some patients might just be a little bit more prone to it. Obesity can be a big factor. If you're a little bit overweight, that can cause a little loosening and more pressure from down below, so it opens up the diaphragm. Just with age, patients can have a little bit of a loosening of the diaphragm. So what happens is a portion of your stomach actually slides up. and that causes a hiatal hernia. So now again, you have acid and things inside the stomach that are in your chest where they shouldn't be. So I think one of the key aspects of this is when do you go and see a provider for reflux? Where a lot of patients are just like, this is something that they don't even know that they have it. Because a lot of you guys have reflux. A lot of people have acid kind of burning in the back of their throat, and they just learn to live with the symptoms. Where they just, over time, they're like, this is just how it is. Or you start avoiding certain foods. You're not eating pasta. You're not eating tomato sauce. You stop drinking lemonade, stop drinking coffee, things like that, because you just know that, oh, it's not good for my stomach. But I think a lot of people don't actually get evaluated and go through further testing that you don't actually have to live like that. You should be able to enjoy the foods that you want to eat. You should be able to eat whatever and not constantly have acid burning the back of your throat. So when should you come in for an evaluation? So whenever, let's say you go to your primary care doctor or GI doctor, a lot of people are going to put you on those acid suppressing medications, pantoprazole, omeprazole, H2 blockers, things like that. That's usually one of the first things that they're going to do. But if you've been on those medications for years and years and years, and it's not helping you, you should see a provider. If you are on these medications for years, it's not like these medications don't come without side effects. So you're on omeprazole for a long time, you're on pantoprazole. You really shouldn't be on those medications for prolonged, multiple years at a time. If you feel like you come off of the acid suppression medications and the acid immediately comes back, see a provider, because that's not normal. You shouldn't need to be relying on these medications for a long, long, long period of time, because then the side effects are going to start coming in. So that's an issue. If the reflux is affecting your sleep, if it's affecting your eating habits, like we talked about, if you notice that you've silently been starting to cut out certain foods and you just think it's normal, like, oh, pasta sauce, I just can't eat that. Or there's certain foods that you're just like, I just can't eat those things. You should see a provider, because we're here to kind of help you take control of that acid and hopefully, restart eating and living the way you should be living. You notice that food or liquid is starting to come back up. A lot of patients, like halitosis can be a problem. If you notice that you're having bad breath despite everything else that you're doing, then those are reasons to kind of investigate everything else that's going on. Dysphagia or swallowing difficulty is a very big issue. Sometimes patients, along with the chest pain, can feel like food gets stuck. They're just like, I swallow, but sometimes tougher meats, things that you're eating, bread, salad is a common problem. Anything that's very fibrous or starchy, it tends to get stuck. That's not normal. That shouldn't be happening. So if any of these things are happening, you're having difficulty swallowing, you should basically be seeing a provider. So what we're trying to offer at Rome, and we're still in the process of kind of building this, but now we have 3 providers. We have Dr. Amodu, we have myself, we have Dr. Hall. So the whole goal is to kind of keep all of our reflux care and everything that we offer in one institution. So the idea is you guys come see us for a consultation. Afterwards, we do all the imaging here, usually upper GI series, whatever imaging we decide that you guys need. It'll all be done at Rome. All 3 of us also perform the upper endoscopies. So usually when you come in with reflux, there's a process or a series of investigations to figure out why are you having that reflux. The idea is that we do all of it here at Rome. So we're creating kind of a specialized heartburn center. So once you come in, all of your care, the continuity stays at Rome. So you don't have to, go to multiple different places, get your imaging, get your care, and come back here. So you have your consultation. If you need imaging, you stay here. If you need an upper endoscopy, we perform those procedures routinely. So we'll be able to tell you exactly what's going on. And then once you come see us, it's not like everybody gets scheduled for surgery. We do the surgery, sure, but we'll evaluate whether you need medications, whether you need surgery. So really kind of a one-stop shop. So once that evaluation happens, then we'll continue to have good follow-up with you. Because one of the most important things to do is maintain follow-up with your foregut surgeon, at a heartburn center, because sometimes, yes, you're on the medication for a little bit, we try it, the medication stops working, then we look for other options. Sometimes there are more underlying causes that we can treat, but that only happens with regular follow-up. So we really want to enforce this idea that, yes, we see you for the consultation, we do the workup, but you keep seeing us after we put you on the treatment. So how do we find the cause? So a little bit about this, I did talk a little bit about it. Once you start having reflux or these symptoms, there are a lot of underlying reasons why you might be having reflux. It can be your esophagus, it can be your stomach, you can have the hiatal hernia that we talked about. Sometimes your esophagus is contracting too much. So how do you figure it out? So in order to do that, we do imaging, and then we do the upper endoscopy, which means just like if some of you guys have had a colonoscopy before, just like having a camera, it's a camera that goes down your throat, and then you're able to see exactly what's going on. So first you have something called upper GI series, you have the endoscopy that we can perform, and all of that testing happens here at Rome. And basically the idea is that based off of your unique symptoms, based off of your history, we'll be able to make sure, tailor the treatment plan according to exactly what you guys need. So what are some things that you guys can do now to reduce reflux? So if you're at home, you're having reflux, you're having some of this acid, you feel it, maybe some chest pain, what are some of the things that you can do even before you see us? So some of the prime causes: don't lie down super quickly after eating. Ideally, there should be at least a 2-hour window between dinner time and lying down, 2 to 3 hours, honestly. So have your dinner, be upright for 2 hours, 3 hours if you can help it. Some walking, stuff like that. Avoid being horizontal immediately after laying down. Another thing is, if you're sleeping and at nighttime you kind of feel that chest burning, you have difficulty sleeping, always keep the head of the bed kind of inclined, maybe about 30 degrees. Whether you have to put a bunch of pillows behind your neck or anything like that, that kind of creating that incline is going to stop that acid from kind of floating back up because it has to work against gravity now. So that's always a better idea. Try to eat smaller meals and smaller portions. So even if you can't do 3 big meals a day and you're finding that after you eat, you just have a lot of bloating, a lot of heartburn, gas kind of coming up, try to portion it out so you have multiple smaller meals a day. You can always, and a lot of people are very good at identifying food that kind of triggers these symptoms just over time, just from having that experience. Like patients will come to my office and immediately they'll be like, I can't drink coffee. I can't eat pasta sauce. I can't drink lemonade. Like, you guys are very good at knowing exactly what triggers it. And obviously one of the main things is going to be trying to avoid those trigger foods until you get the help and the treatment that you need. Tobacco, alcohol, terrible for acid reflux. It really, really exacerbates the acid. It really causes a lot of pain. You're going to have chest pain. So avoiding smoking, avoiding alcohol altogether is going to be very helpful. And if some people are struggling with weight, if there are patients that are overweight that come see us, being overweight actually puts a lot of pressure on your stomach and can force the acid to kind of come up to your esophagus. It can loosen your diaphragm a little bit. So one of the main things is to ensure that you maintain a healthy weight, which we also help with because we are here at Rome. We're a bariatric center of excellence. So if there are patients struggling with weight, you can come and see us. We do a lot of weight loss consultations, nutrition. We can help get you guys the help that you need there as well. So it really goes hand in hand. Weight, acid reflux, GERD, everything goes hand in hand. So how do the reflux medications help? So the number one thing that a lot of you might be on is the acid reflux medications. So either they're antacids, they can be H2 blockers, you can have PPIs, pantoprazole, omeprazole. That's one of the first things when you go to your primary care doctor or your gastroenterologist, maybe stomach doctor. The first thing they're going to do when they hear GERD is to either counsel you about some of the conservative measures that we talked about, some of those lifestyle changes. And the second thing they're going to do before you guys usually come to see us is everybody is on an antacid medication or a PPI. So the way these medications work is they reduce the acidity and they can kind of prevent the acid from building as much and kind of coming up to the esophagus, but they're not going to completely stop acid production. The idea is that they can lower it, but if there are underlying causes that there's a reason that you're having all of this increased acid production, you have a hiatal hernia, things that can be fixed, operatively, then that won't be fixed by being on a PPI or an acid-reducing medication. So there is a role for medications, and sometimes just for a short period of time, they can just help, reduce acid production, but it won't completely eliminate the acid production. And if there's a defect in your stomach or there's an anatomical issue, something is the anatomy, just like a hiatal hernia, the medications won't really help.
I have a question.
Yes,
Being on the pantoprazole,
yes.
how long, first of all, how long before you start seeing results with it, does it normally take to be on it?
It takes some time. I would say at least 2 weeks, like maybe about 10 days or so. A lot of them, like if it really depends on what you're on. Like proton pump inhibitors take a little bit of time. It might take a couple days. And a lot of patients actually don't take proton pump inhibitors correctly. So hopefully your primary care doctors and your gastroenterologists, if you're on omeprazole or pantoprazole, you have to take it in the morning on an empty stomach. And then 30 minutes after that, you can start drinking or eating, anything that you want. So that should be part of the education of taking those kinds of medications. But it does take a few days.
Okay, so, and then once you're on it, is it supposed to help it so that it doesn't feel like there's something stuck in your throat?
That's,
It's a different
yeah.
thing.
Basically the issue, other than I don't get the burning sensation, I just get feels like there's something there. So, I mean, will the pantoprazole, is that supposed to help that feeling as well in the back of your throat?
Usually not. So things like chest pain, things like difficulty swallowing, those are things that you really should see a provider for, because that is the kind of stuff that we do the endoscopy and you discover exactly what's going on. That means there's some kind of anatomical, usually some kind of issue that is being kind of disguised by the PPIs and things like that. But food getting stuck, chest pain, these are very common symptoms that there's something more going on. So usually those are not fixed by PPIs. Yep, absolutely. Yes.
What do you call yourselves other than gastroenterologists? What's the difference?
So we're surgeons. So the gastroenterologists are not able to do surgeries, or they can do endoscopies.
But you work hand in hand with them.
We work hand in hand with them. That's correct. So usually what they can do is they can do the endoscopies. We do them ourselves as well, but they can do the endoscopies, and sometimes they can order the imaging. But if you need any further workup than that, if you need surgery, you have a hiatal hernia, you need a surgical fix for reflux, then they'll refer them to us. So we'll be the ones taking care of that. Yes.
I'm on omeprazole,
Okay.
and I used to take it in the morning
Sure.
before I ate, but it really didn't help me that well. So Dr. Burns had told me
Mhm.
to take it in the afternoon before I have dinner,
Okay.
which I do, and it worked.
It actually
worked
helps?
much better.
Okay.
So that's when I take it,
Mm,
about an hour before I have dinner.
Sure.
So
The key is to take it on an empty stomach.
Yeah,
So
well,
if you are good, so if you're taking it on an empty stomach, it's definitely going to be more effective. Some patients I find, just because they start eating earlier in the morning, it's better for them to be taking it in the morning, 30 minutes before they start eating. But the key is to take it on an empty stomach when the actual, acid is prevalent.
Yeah.
So it's good.
so it's okay then. Well, it is. I mean, it's helping
Yes.
me at night, so I
Yes.
will continue to do that.
Yep,
just
yep.
For the time being.
Definitely okay, but patients who are also on PPIs or omeprazole chronically, you should, if you haven't had one already, you should definitely come see us for an endoscopy. Just because,
I have
good.
that on a regular basis.
Perfect. Alrighty. So this is kind of one of the things that we wanted to touch on, being that we are also a bariatric center, that obesity, reflux, hiatal hernias, all of these things really go hand in hand. So if a lot of patients come to us, they're having reflux for a long period of time, and they might also need a little bit of help with their weight. So what this increased weight does is there's increased abdominal pressure. So you have a large abdomen, there's a lot of pressure inside. The pressure will kind of push your stomach up. So in order to kind of precipitate a hiatal hernia. So your diaphragm already, there's a lot of pressure against the diaphragm. The diaphragm opening gets a little bit looser. So now a portion of your stomach slides up. We see that with a lot of patients that come in with reflux and have problems with their weight. So in order to have a treatment plan specifically for those patients, what we suggest is you see us in our bariatric center. We work with you first to kind of take off that weight, healthier lifestyle, nutrition. If you need bariatric surgery, we also offer bariatric surgery. Everything is done here at Rome. So we'll get you the treatment you need for the obesity, being overweight, and then we tackle the hiatal hernia. Sometimes you can do it at the same time. Sometimes they need to be done in two-staged operations. So, when does surgery enter the conversation? When is it not enough that you've been on medications? You kind of have the symptoms that you've been having. When do we start that conversation about a surgical alternative? That's kind of that's the main question that everybody sees us for, or that's when GI starts to refer their hiatal hernias and patients with reflux over to us. So, the idea is that it's very individualized. So it's hard for me to kind of say without meeting the patient and knowing your specific history, the surgeries you've had in the past, how long you've been on medication. So all of these things are done in a very individualized basis. When you come see us, you'll have the initial consultation. We'll talk a little bit about things that you guys have tried. Have you tried reflux? What options have you guys explored? Then we'll send you for some imaging, the upper GI series, whatever we need to kind of diagnose the underlying problem. Chances are you will have an endoscopy with us, or if you have had endoscopies with GI, that's perfect because we can always get the records from the other GI doctors. Once we have all of those things, we're very easily able to tell whether or not your reflux is going to improve with surgery. Is there something surgical that we can fix? Or is there a surgical treatment that we can offer you? And the idea is that no one should be on chronic medications, right? Like you shouldn't be taking omeprazole, pantoprazole for years and years and years. You shouldn't become dependent on this medication. That if you stop taking the medication, you're like, it's unbearable. I can't eat, I can't sleep. Even one day without my medication, I'm just all out of sorts. Then that means there's something underlying going on. Come see us for testing, come see us to kind of get an evaluation, and then we'll be able to figure out what to do. The idea is to get you off of those medications. After a surgical repair, if you have a hiatal hernia, we do some other kind of surgery for your reflux, we're very quickly able to wean off the acid reflux medications. We've had a lot of patients even literally after we do the surgery sitting in the post-operative area saying that their reflux is gone. So it's a very night and day difference, and we don't want you to be dependent on those medications. So the goal of the surgery is you have the surgery, you have the fix, no more medications. So how is the hiatal hernia repaired? Without going into too much detail, we'll just briefly, very quickly talk about the surgery. And I know I keep kind of emphasizing the same points, but up here you have your esophagus. We have the diaphragm that we talked about that separates the chest from the abdomen. And then you have the stomach sitting down here. So a hiatal hernia is there's a loosening of the diaphragm. So you have this, the stomach is sliding up. So what we do is we take that stomach, we pull it back down, and then you close, you make this narrow, you make the diaphragmatic hole narrower. So now the stomach stays where it's supposed to, and it's not sliding back up into your chest, causing that reflux essentially. Most of these surgeries are, I had a slide on. So most of these surgeries are done minimally invasively, meaning when you come have the surgery, or we do it all robotically. So there's a robot, we operate the robot ourselves, and you have small cuts instead of the way these surgeries used to be done was that people were having massive incisions. Nowadays, we have a camera, we have the robotic instruments, you have maybe 4 or 5 small cuts in your belly, all 1 centimeter long. We go in there, repair the hiatal hernia. We're actually able to get very good visualization. We have better cameras, better visualization. Rome actually has the latest robot. There's different versions of the robot that come out. We have the latest robot here. It's the Da Vinci 5. So we're able to use that and perform the surgery. And it's a night and day difference for the patients because now patients have the surgery and 99% of them go home the next day. So if there's no complications, they're tolerating clear liquids, you're in the hospital for a night, you go home the next day. They're up, they're walking around the following day. Most feel like they haven't even had surgery 3 or 4 days after the operation. So it is the robot is really able to kind of aid us in offering minimally invasive surgery. What we talked about, so the reflux operation is very personalized. So we kind of, when you come see us, we'll come up with a personalized surgical plan. We'll talk about your goals, we'll talk about your preferences, any other medical conditions, if you had other abdominal surgeries, how big is your hernia, because now we have all that information with the testing, the EGD, all of that stuff. So it'll be a very personalized plan. We'll be able to decide whether or not you should continue your medications, should we add medications, or should we start talking about surgery? And of course, if patients are overweight, just like we talked about, we can always consider bariatric surgeries, bariatric options as well, because everything will go hand in hand. So, what does the recovery look like? The recovery, the first few days, like we talked about, you're in the hospital for a night. Usually, you go home with liquids. When you're considering this kind of surgery, before and after, you meet with our dietitian. She's also in network. So we are able to organize telephone calls with her. She talks to you before the surgery. She talks to you after the surgery. The first couple of weeks after the surgery, you're on a specific diet. So you have some clear liquids. For the first 2 weeks, you drink some thick liquids because you've just had surgery, so you don't want to stress anything out. And then we slowly, over the next month, we progress you back to solid foods. You will get back to solid foods. You will start eating the things that you should be eating, but it does take a little bit of time to kind of get there again. And then, of course, we really emphasize follow-up. We want you to come meet with us. We meet with you a week after the surgery, 15 days after the surgery, the first month after the surgery, and then afterwards, every 3 to 6 months, we're going to be consistently meeting with you. So we can track your symptoms, and we know exactly, if you need a fix, you need repeat EGDs, all of that stuff. So just to kind of get off of the reflux tangent a little bit, we did also want to talk about some of the other minimally invasive surgeries we offer. So Dr. Amodu, myself, Dr. Hall, we all kind of offer more minimally invasive surgery. We're trying to get away from, a lot of open surgeries because the recovery time is better. You guys have smaller incisions. People are able to go back to work sooner. So in case, inguinal hernias, you can have, just like we talked about hiatal hernias inside, you can have hernias in other places. So you can have hernias in your groins. People can feel a bulge there. You can have hernias at your belly button. Sometimes people have bulges there as well. Those are options that if you come see us, we can definitely take care of those. A lot of them are done robotically. If you know anybody that has gallbladder problems or patients that have pain up here on the right side after they eat, come get evaluated for a gallbladder. So we do multiple different kinds of hernias. We do gallbladders. All you have to do is come see us for a consultation. But yeah, so I think that's mostly kind of what we wanted to talk about. Swallowing, we talked about hiatal hernias, how weight and reflux kind of go hand in hand. And then, kind of wanted to emphasize that all of your care will be at Rome and it's a pretty individualized treatment plan. So we'll kind of open up the floor. You guys have any questions for us? Anything that you want to talk about?
Does the mucus have a lot to do with this?
It's possible.
You want to answer?
It's possible. Like excessive production of mucus, yes, you could. Like if you have reflux kind of draining into kind of like the back of your throat, you could have symptoms like that.
That's the post-nasal.
Post-nasal drip, correct.
Post-nasal. Yep, one of the questions was, does mucus have a lot to do? I'm just going to repeat your guys' question so whoever's online can also hear what you had to say. But I guess the question was, does mucus or kind of stuff feeling caught in your chest have a lot to do with reflux? And it absolutely does. If you have a hernia, hiatal hernia symptoms, some of the main symptoms are food getting stuck in your throat, mucus, constant coughing up mucus, and chest pain. Yes?
Is it dangerous to be on long-term omeprazole? I mean, is there, I may know there's side effects, I read them, but I mean, it works for me, okay?
Mm-hmm.
I don't have any problem with it,
Sure.
but if I stay on it, am I taking a chance to develop something really bad?
Sure. So the question was, is it dangerous to be on long-term omeprazole, pantoprazole, these kind of PPIs that we're talking about? Yes. The short answer is basically, yes, people use them for years and years, and all the side effects that you read about online are definitely true. One of the major side effects that kind of concern us, especially as people start getting older, is osteoporosis. So there is a link, meaning that kind of your bones start getting demineralized or they're just not as strong. So that is definitely a concern from PPIs, and that's one of the main things that we do worry about. There are other side effects, but they are real side effects.
Yeah.
So the idea is to really not be reliant on this medication for reflux. Yep. Yeah.
I've been on the medications for well over 20 years, give or take.
Okay.
And I'm tired of popping pills.
Yeah.
That is one thing I am so over.
Absolutely.
But they keep changing them on me
Mhm.
because, I mean, my ass gets so, I don't feel it in my throat anymore. It's numb. And
Sure.
It's
Mhm.
gone. So they're like, okay, that one's not working. Let's give you this one.
Yeah.
All right, that one's not working. Let's give you this one.
Sure.
I'm like pilled out.
Yeah.
I get to days to where I'm like,
I don't even take it
Mm-hmm.
because I'm sick of doing it.
Yep, absolutely. So I guess the question was kind of, how long is too long, right? That the
Yes,
the
yes.
proton pump inhibitors their pills are constantly changing. You go to a gastroenterologist, it's multiple different pills.
Yes.
And that's a very valid question, especially I would say that if you've tried one medication, a lot of them work similarly. Some are a little bit stronger than others, but if you've been on one medication for at least like, let's say 4 or 5 months, and it's not helping you, and they keep changing the different medications, you should definitely have an evaluation. Definitely come have an endoscopy, because there can be definitely underlying reasons that you're having this acid reflux that could be a surgical cure instead of just trying different medications for a really long time.
It seems like every time I go in for the endoscopy, I've got gastritis, I've got GERD,
Yep.
I've got Barrett's, my hiatal hernia's there.
Yep.
But
Mhm,
it's,
mhm.
okay, let's try this medicine.
Sure.
You know, it's, now I'm on one that I have to take twice a day and then another one I have to take at bedtime.
Yep. And that is a really good point that we didn't touch on. A lot of you might not know what Barrett's esophagus is. It's kind of a clinical condition where if you have, let me go back to that image that I had. Let me see if I have a. So if you have all this acid, acid is supposed to stay in the stomach, like we talked about. We have cells here that are protective because acid belongs in your stomach. The cells in your esophagus are much more gentle. Acid does not belong there. So once this acid starts kind of creeping up and hitting your esophagus, it starts burning it. So it starts burning it to the point where these cells transform. And that's called Barrett's esophagus. So a very real, I wouldn't say complication, but a very real like next step or sequela of constantly having acid reflux is you start to develop Barrett's esophagus. And we want to catch acid reflux before that happens. If you already have Barrett's esophagus and you have a hiatal hernia, then you should definitely have your hiatal hernia repaired because that's likely the reason you constantly have that acid. The idea is to figure out what is causing that acid to come up and fix the underlying cause. Otherwise, the Barrett's, the esophagus keeps getting burned and burned and burned. And we definitely don't want that to keep happening. Yeah.
So the endoscopy, if it was, if you were diagnosed with Barrett's, then what?
So if you're diagnosed with Barrett's, the first thing we have to do is treat the Barrett's, meaning you are already on acid suppression medication. We do acid suppression medications. You will have surveillance for Barrett's esophagus. We'll test if you have a bacteria or not. It's called H. pylori. If you have that, we give you more antibiotics and things like that. But aside from the Barrett's surveillance, your gastroenterologist can keep surveilling you for Barrett's, but the number one thing, and a hiatal hernia or a repair that we do, it doesn't cure Barrett's, it's going to stop it from progressing. You will have treatment for your Barrett's, but if you treat just the Barrett's and you don't stop that acid from coming up, you're just going to keep having Barrett's because the acid is just going to keep burning your esophagus. So if you have Barrett's, you should definitely have the endoscopy, figure out what the reason is that I constantly keep having this acid coming up and treat that. And that is what we can help you with. Yes.
When you talk about surgical options, are you talking fundoplication?
Yes, fundoplication, that is a surgical option that we do. So the question was, in terms of hiatal hernia repairs and surgical options, what's a fundoplication? So we didn't kind of get into the weeds of how we do the surgery here because this talk was a little bit more about, reflux and things like that. But if you guys have specific questions about the surgery, more than feel free to ask, feel free to come visit us. But what you're saying of fundoplication is the specifics of the surgery is that, you have your hiatal hernia, the stomach is sitting inside your chest. So we bring down the stomach where it's supposed to be sitting back in your stomach. And sometimes in order to control the reflux or the acid that's coming up, the stomach, a portion of it is actually wrapped around your esophagus. And that wrap is called a fundoplication. But again, we have to do a lot of the testing, the EGDs to determine if you're a candidate for that. A lot of people do get the fundoplication, but it's just a part of the surgery that you're asking. It's a way for the reflux to stop coming up. Yes.
Does it matter what size the hernia is? Because I've been told I have a small one,
Mm-hmm, mm-hmm.
and I have a weak LES.
Sure.
That sounds right. That's what they said.
Yeah.
So does that matter as far as could a small hernia be causing that type of acid reflux problems?
A small hernia can absolutely cause acid reflux problems. It is also very, It's kind of subjective. So when we say like small, medium, large hernias, it is a little bit difficult to tell only on an endoscopy. You need like an endoscopy, you need imaging to exactly figure out how big the hernia is. Usually one test won't be as specific. Sometimes certain people can think it's a little smaller, things like that. But small hernias, just a little bit of herniation can definitely cause symptoms. Yep. Sometimes the smaller hernias, if this defect is a little bit smaller, and the hernia is kind of sliding up as a smaller hernia, it can be more painful because now it's kind of just stuck in there and you constantly feel like something is stuck. If this is wide open, patients have symptoms, but sometimes those can be even less than the patients that have smaller hernias. Yeah.
I've had my esophagus stretched like 30 times.
Okay.
Okay. And finally, my doctor, my gastroenterologist I go to, said, you have a hiatal hernia.
Okay.
It's very large. I can't do anything more for you. You've got to live with it.
Right. Well.
And this is where I'm having problems because when I eat, I get pains in my over my rib cage where I can't move.
Sure. I'm not surprised, especially if you have large hiatal hernias. I don't think it's necessarily true that we can't do anything for you, but right, which is important. That's why I think we have these seminars. We kind of want to come out and talk to you guys that, just because one person said we can't do anything for you or there's no way to kind of go about it, see a specialist. We're here. We'll do the testing. We'll do the EGDs for you. We'll get some more imaging. And if there's a surgical cure, then we're more than happy to offer it. But it doesn't, just because one provider said we can't do anything for you does not mean that's the case. Yes.
I had the hernia repaired
Sure.
over a decade ago.
Okay.
Through my back.
Oh, wow. Okay.
Because it was going through another hole in my diaphragm instead of the correct hole, so he fixed that.
Sure.
And he wrapped it or whatever he did.
Yeah.
Now I'm still, after a decade, starting to have more problems and I lose my voice.
This stuff keeps coming back.
Although it's all numb because of years. I've been on omeprazole for 30 years.
So the very good question too. The question was, I already had a hiatal hernia repair in the past, but I'm still having symptoms. We also see that. We have seen that in the past. Some patients, hiatal hernias, just like any hernia, even if you have the best repair in the world, sometimes they can come back. And some of the things that cause it to come back, patients, they're smoking, sometimes they might be drinking, sometimes they put the weight back on, and then the weight kind of, like you have increased abdominal pressure. So there's multiple reasons why the hernia can come back, but it doesn't mean that we can't offer another repair or we can't evaluate whether or not you're another candidate for surgical repair. So just because you've had one once doesn't mean that there can be other options as well that we can try, other surgical options.
So we got one online real quick. And
Okay.
The person is asking, would I need to repeat a procedure after the original surgery? It kind of ties in with what she was talking about.
Sure. There are multiple procedures that we can offer that, there are definitely revisional hiatal hernias. So if you've had a hiatal hernia in the past, there are ways to go back in and repair it again. There's ways to enforce it with mesh. So there are things that we can do, even if you've had it done previously, to go back in and either evaluate it or, perform a better repair. So there are ways in certain cases.
I'm wondering how long this method of repairing hiatal hernias has been available.
Oh gosh, people have been doing hiatal hernia repairs for years. The robotic. Oh, the robotic. I would say, what do you think, Leo? Maybe the last
decade, 20 years.
10 years or so maybe.
Yeah.
Because they've been doing, just like she had the hiatal hernia repair done and they went through her back. So that was a common method previously where you would either go through the front, people had big open incisions in the back. So we've been doing hernias like that for years, for hundreds of years. But the robotics and laparoscopic, more so I would say in the last decade, where you can now do it, we get better visualization, smaller cuts, patients are in the hospital for a less amount of time, and they recover a lot faster. Yeah. Yes?
If one has a damaged esophagus to the point where it's like only 3 centimeters and food, even drinks, have a hard time going down, is it ever possible to take that damaged part of the esophagus, remove that little part and repair it that way to have a less constrictive pathway on your esophagus?
I guess the short answer is that it could be possible. The longer answer is that that's a very invasive procedure that you're talking about. So unless it was, you were having extreme problems, you just really couldn't swallow, that piece of esophagus is dying, it's necrotic.
To the point where a food tube is needed because you cannot swallow.
Yeah.
And
Yeah.
the person's becoming very depressed and suicidal.
Yeah, if you need a food tube, like that's what I mean. If it's really getting to that point, then something like that can be considered. But until that, because actually removing a piece of the esophagus and putting it back together is a whole different ballgame. It's a much more invasive surgery than some of the things that we've been talking about. But it's possible. It's possible. Yep. Yeah. I think that's pretty much it. Anybody have any other questions? Anything else that they want to kind of chat about?
I just have one more
Yes,
question.
absolutely.
I don't mean to put you on the spot,
Of course.
but how many of these have you done?
How many of these have I personally done?
Including training.
Including training. I guess in training, we've done at least more than 200. We had definitely both of our programs were very strong in foregut training, minimally invasive training. So we do these cases, no one gets up and starts doing these cases by themselves, but it's not like, hey, walk into training first day as a hiatal hernia, but we have definitely graduated from these programs. We've seen numerous kinds of hernias, been able to kind of take care of these patients, and now we're practicing on our own. So it took us a while to get here, but.
And we've both done these cases here at Rome.
Yes.
We've had a pretty good number.
Tell me a little bit about what weak motility is.
Yes. So weak motility specifically has to do with more so your esophagus. I mean, you can have so basically your esophagus, your stomach, your small bowel, everything has something called peristalsis. Your whole intestinal tract contracts like this to keep pushing food forward. If that is impacted, if your esophagus, when you swallow, your esophagus is supposed to contract. It's supposed to keep pushing that food down. That's normal motility. Sometimes your esophagus is just not pushing food down to the degree that it should be. So it's just moving through slower. Sometimes it gets stuck. Patients have that feeling that things are getting stuck. So that is weaker motility. You're not pushing food through at the rate that you should be.
Okay, and if you have that, are you still able to, are you a candidate for surgery, or does that take you out of that?
So those are very specialized cases. We would have to do some additional testing, just like the testing we talked about. We do the upper GI series. There's something called manometry. They put kind of a probe down. There are degrees of motility. Some patients have very bad motility. Some patients have a little bit of motility. So really depending on where you fall, just like I said, these things kind of become very nuanced. So each plan is very personalized to the patient. You can be a candidate for surgery. You might not be a candidate for surgery. Yep.
What are your thoughts about manual movement of stomach back down? There's procedures where you can.
From the outside, you're saying, like a massage, kind of. I don't think they're very effective. I personally have not seen a manual massage of that sort, but if from the inside, you're not going to be able to move your stomach. Where your stomach is sitting and kind of moving up the hiatus, it's impossible to do that, basically, with manual massage. I wish that was the case, but then we wouldn't have a job, really.
Not just that, when the stomach has been displaced and it's been in the chest for a while, you have a lot of scar tissue that just forms around it. So it's unlikely that just external manual manipulation would be able to break up the scar tissue that's actually in your chest. So not very effective, just the science of it.
Very good point. Yes.
What for a person who has moderate gastroparesis, but also has GERD and the hiatal hernia and all the other stuff? Would that person possibly be a candidate?
Again, very complicated cases. Like these things definitely happen. That's why it is very important to see specialists in a heartburn center instead of just relying on GI or just relying on one provider, because we do see a lot of patients with multiple things going on. Like you said, some patients have motility issues, some patients have hiatals, some patients have gastroparesis. So it's not like everybody that comes to us is going to be very straightforward. We're fixing the hiatus. But we will be able to tailor the plan for you. So we'll be able to kind of evaluate you with multiple testing, things like that. Sometimes you are a candidate, sometimes you're not a candidate. But what are your other options? And we'll be able to explore that for you. But those are good questions. Yep. Yes?
I heard of something recently called LPR. I think it's supposed to be something similar to GERD.
Okay. What is the LPR?
Laryngopharyngeal reflux.
Oh, I see.
Yeah.
I see. I mean, these are again, they kind of, we'd have to do some evaluation for it. So that's basically when the reflux is not, maybe it's not necessarily, it's happening kind of higher up. Like you have another muscle up there that might be refluxing, might be pushing the acid up. So there are different areas where you can have that reflux. Treatments are different for the different areas, but hard to say until we, talk to you one-on-one kind of.
Just important to note, I'm sorry, that
Yep.
laryngopharyngeal reflux falls under the specialization of ENT. So we as foregut surgeons, we deal more with gastroesophageal reflux. Laryngopharyngeal reflux, you should see an ENT surgeon, ideally.
Right. And even if it's hard for you guys to make that distinction, if you see somebody, we'll be able to point you in the right direction. Even if you come see us, we're like, okay, this is something that an ear, nose, and throat guy should see. We'll send you over. We'll make the referral. We'll handle all the referrals and everything like that. Yes.
I guess talk a little bit about like life after the surgery. Like, are there foods you won't be able to eat, or things that you might have to do differently, or anything like that?
Sure. So after the surgery, so before the surgery, for a couple days, we kind of put you guys on a clear liquid diet just to make things a little bit easier for us, make sure you're not producing tons of acid, things like that. After the surgery, again, what has happened, I mean, it's pretty, even if from the outside it looks like you have tiny cuts, from the inside you've had a major operation. So there is a lot of kind of swelling, edema, things like that happen inside. So we progress you very slowly. So the first day, while you're in the hospital, sometimes you're on just clear liquids. The next day when we send you home, you're on some thicker liquids for the first 2 weeks. So it's not so much pain from the surgery, it's more bloating. Patients sometimes have a little bit of like a lot of gas pain that they kind of deal with. But for the first 2 weeks, you're on thicker liquids. The next 2 weeks after that, you're on soft foods, think like mashed stuff, pureed stuff, cottage cheese, things like that. And then after the month is over, we start integrating your solid foods back in. What recovery looks like, recovery is a little bit different for everybody. Some patients have almost no symptoms, they do well. Some patients have some symptoms concerning the inflammation. It also depends, like hiatal hernias can come in different sizes. If you had a very big hiatal hernia, we've done a lot of work inside, we kind of reduced it, wrapped things up, you might have more inflammation. So the idea is that you progress slowly, but you come see us for regular follow-ups, because that's how we know, how are you doing exactly? Do we need to start you on more medication? How are you doing? How are you progressing? Things like that. And the idea is that, immediately after the surgery, you stay on your omeprazole, pantoprazole, but hopefully a couple weeks after the surgery, let's say a month or so out, we wean you off, and we wean you off slowly. So the first week, maybe a month after the surgery, you take your medication 3 days a week. Then the week after that, you take it 2 days a week. And then the week after that, we're like, take it as needed. And it's not that, your symptoms will be significantly less after the surgery. You won't be dealing with it on a day-to-day basis, but that doesn't mean that one day you're going to wake up, you have some pasta sauce or something, and you never have GERD again in your entire life. It's just a fact that once in a while you will have heartburn, but you won't be relying on medications, and you'll symptomatically you'll feel a lot better. But sometimes the same trigger foods can, here and there, it can trigger heartburn. But you will be able to eat those foods, but they might, trigger some heartburn here and there, just like anybody with a normal esophagus.
But it's not gonna be an everyday thing.
No. And the idea is that you shouldn't be on medications every day for it either. Like once in a while, well, I don't know, 1 month, you have like a couple wines at night or something like that, and then the next morning you wake up with reflux. That doesn't mean the surgery's failed, it just means you drank the night before, Yes.
If one has an excess of postnasal drip for many years.
Mm-hmm.
What type of doctor should be seen and what could be done about that? And does that contribute to what's going on in any of those pictures?
Postnasal drip, that's a very good question, and that can absolutely be caused because of reflux symptoms. A lot of people have, what happens is the acid is coming up, it's irritating the back of your throat, and that can still travel higher and like irritate your nasal passages as well, basically causing that feeling of postnasal drip. So patients that can absolutely be due to reflux if that is one of your symptoms. It can be due to reflux if that is one of your symptoms, because it can be the acid that's coming up and kind of tickling. Everything is connected. So if you're having very severe acid reflux, patients can have a slight chronic cough because of it. Some patients come to us and they're like, I've just been coughing for years. Like it's like a slight tickle in the back of my throat. I just cough and cough and cough. It's not allergies. It's what it is acid coming up and irritating the back of your throat constantly. That's causing you to clear your throat and cough. And the same goes for postnasal drip. I'm not saying that, that's the only cause of postnasal drip, but it can definitely contribute.
So, but a gastroenterologist would be taking care of that? That's what you would see a gastroenterologist to take care of that, or suggest another specialty?
You can see a gastroenterologist. They'll probably do testing. They'll do an endoscopy for you to kind of determine if you have that reflux. If you want to see us, we do all the same testing to figure out if there's reflux. But they should point you. They should be able to differentiate if this is due to reflux or if this is due to other causes. But reflux is always a possibility. Yes.
So do we, because I've been going through a lot of procedures
Sure.
myself. Now, do we just make an appointment with you all if things aren't working well?
Yeah, absolutely. Right, Lisa? We're able to kind of.
There's somebody on site today that can schedule you if you want to leave with an appointment, or we have appointment cards, and you can just call us when you feel like you're ready. We'll just schedule you for a basic consultation, so no tests will happen that day. We'll just have that one-on-one consultation with the surgeon to determine the next steps.
Okay, thank you.
Yep.
That's really much.
Yeah.
Well, you guys have been an amazing group, very
Thank you.
interactive with all of your questions, very open, so we appreciate that.
You guys were great.
Thank you.
Well, thank you
Thank you
guys
for
for
coming.
coming. Yep.
Thank you.